My name is Ihoma Alino. I am an internal medicine resident with Morehouse School of Medicine, Atlanta, Georgia. I'm here to present a clinical vignette titled Transverse Myelitis, a presentation of neuromyelitis optica spectrum disorder, NMOSD, also called Devic disease. This is a rare inflammatory disorder of the central nervous system caused by disease-specific aquaporin 4 antibody. Some studies have also shown NMOSD as an initial presentation of systemic lupus erythematosus (SLE). Here we present a case of NMOSD presenting as transverse myelitis in a patient with a family history of SLE. 20-year-old female with no significant medical history presented to the emergency department with 3 weeks history of bilateral arm paresthesia, band-like numbness extending across her back and waist, 2 weeks of lower extremity numbness and tingling, and 3 days of progressive weakness leading to inability to ambulate. She reported associated neck pain, described as a pressure, constant, non-radiating, 8/10 intensity, with no known aggravating or relieving factors. Vital signs were significant for sinus tachycardia. Physical examination was significant for lethargy, reduced strength of left upper extremity and right lower extremity, full strength in the right upper extremity and left lower extremity, diminished pain prick sensation in the mid-thoracic region, brisk reflexes, and inability to stand. She was also noted to be retaining urine, necessitating insertion of Foley's catheter. Labs revealed a normal chemistry, normal CBC, and negative ANA. Lumbar puncture was significant for lymphocytic pleocytosis with WBC count of 94 and elevated protein of 87. She had a normal MRI of the brain, but MRI, cervical, and thoracic spine were remarkable for extensive expansal cord signal abnormality with few patchy areas of enhancement involving cervical spine cord extending from C2-C3 to T2-T3. Additional areas of central cord signal abnormality involving the thoracic cord from T9 to T12 with expansion of conus with mild enhancement. She was started on high-dose glucocorticoids, 1 gram daily. Less than 24 hours into admission, her physical exam deteriorated with worsening muscle weakness, worsening brisk reflexes, and she developed clonus. There was a high index of suspicion for Devic disease, and she was transferred to the neurology unit for plasmapheresis. Extensive workup was performed, and NMO antibodies came back positive by day 7 of admission. CSF later revealed 2 well-defined gamma restriction oligoclonal bands, which were not present in corresponding serum. Patients completed a 5-day course of IV methylprednisone and 5 sessions of plasmapheresis. Physical and occupational therapy were consulted and worked with patients during hospital course. Physical examination improved. She was also weaned off of Foley as she could void spontaneously. There was increase in strength, but she remained significantly weak. She was discharged to a subacute rehab after 10 days of admission with neurology outpatient follow-up and plans to commence long-term immunosuppression with rituximab. NMODS is characterized by severe immune-mediated demyelination and axonal damage predominantly targeting optic nerves and spinal cord astrocytes, but also targets the brain and brainstem. There are 3 main presentation pathways of this disease, of this spectrum, and it includes optic neuritis, transverse myelitis, and intractable nausea, vomiting, or hiccups. And these correspond to areas of the CNS destroyed by the aquaporin 4 IgG antibodies. In conclusion, clinicians should have a high index of suspicion for NMODS in young patients presenting with rapidly progressive neurological symptoms with unclear etiology. Thank you for your time, and I hope you enjoyed my presentation. Thank you.